Welcome to the session 2 of this insulin therapy workshop. Here I'm going to start with the case. This case number 5. 67-year-old male is diabetic for 25 years. He is on metformin 1 gram 2 times, glimepiride 2 milligram 2 times. His fasting blood sugar is 200. Postprandial blood sugar is 350. HbA1c is 10. So how are we going to manage this patient? Here, patient is on optimal dose of metformin. Patient is also taking glimepiride in a reasonably high dose. We can go glimepiride up to 6 mg daily. Here, patient is on 4 mg. This is also very high dose. So the question is, are you going to hike the glimepiride dose, or you're going to add another OHA? Lot of other OHA from other classes are available, or you're going to add insulin on top of these two drugs, or are you going to take away some drugs and start only on insulin? Before discussing the answer, let us have a quick glance at the pathogenesis of type 2 diabetes. Type 2 diabetes is because of insulin resistance. At the onset of, at the initial years of type 2 diabetes mellitus, beta cells are well functioning. The problem is with insulin resistance. The insulin secreted by the beta cells cannot exert its full action because of resistance. To bring down the sugar, what the beta cells do, it will try to produce more insulin. In the initial years, the total insulin level of a patient with type 2 diabetes mellitus may be much higher than a normal individual. But as years goes by, insulin resistance increases if patient do not practice a good diet and lifestyle, and because of the overworking, beta cells starts to die off. They die off in an accelerated rate, and after 10-15 years, majority of the beta cells do die, and at 20 years, it is very less likely for enough beta cells to be still there in the pancreas. So after a long duration of diabetes means, type 2 diabetes means, patient has beta cell failure. If the patient is having beta cell failure, this glimepiride is not going to act. No other insulin secretagogues is going to act, because they act by squeezing out more insulin from the available beta cells. If available number of beta cells are very less, how can they act? They cannot act. So, is there any point in hiking the glimepiride dose for this patient? There is no point. Is there any role in adding another drug which results in increasing insulin secretion from the beta cells? No, there is no enough beta cells. The best solution is always insulin. So, the question is, if you are going to add insulin, should we add on top of this existing two drugs, or should we remove both of these drugs, or can we retain one and add insulin? So we'll see. The evidence is telling that sulfonylurea in combination with insulin is associated with increased mortality when compared with the combination of the insulin and metformin alone. So it is not wise to combine sulfonylurea and insulin. I have seen many patients, diabetes patients, coming to me who are on insulin and sulfonylurea, glimepiride and insulin, glipizide and insulin, glycoside and insulin. These sulfonylureas are not stopped. Why? There is no benefit in adding insulin and sulfonylurea. Sulfonylurea squeezes out insulin from the beta cells. But anyway, you are giving insulin externally. Then why do you want a sulfonylurea? You can increase the insulin dose. There is no point in using sulfonylurea. Moreover, there are evidences telling that sulfonylurea in combination with insulin can increase the mortality, cardiovascular events. So don't use. You can use metformin. Metformin is always beneficial to combine with insulin because metformin reduces the insulin resistance. So the external insulin which you give can act in a better way. Metformin need to be stopped if there are other contraindications like renal failure and all. But otherwise, we need to continue metformin with insulin, but not sulfonylureas. This is another case. This is a similar case. 67-year-old male, diabetic for 5 years, metformin 1 gram, glimepiride 2 milligram, fasting blood sugar 200, postprandial blood sugar 300. HbA1c is high, it's at 10 milligram or 10 percentage. Here the only difference is our previous patient had 25 years duration of diabetes, but this patient has only having 5 years duration of diabetes. So there is a big difference here. 5 years means there are enough beta cells. Actually, these beta cells are doing enough work. The problem is more with the insulin resistance. But with this metformin, optimal dose of metformin and glimepiride, we are not able to control the sugar. So what we can do? We need to add an insulin. But still, as the duration of diabetes is less, this glimepiride which we are giving is acting actually. Enough beta cells will be there. This glimepiride is acting, but we are not getting the blood sugar control because of two reasons. Either the insulin stimulated from the beta cells through by glimepiride is not enough, or the insulin resistance is very high, so that this available drugs is not enough. Anyway, we need to plan an insulin. Here, fasting blood sugar is high. Postprandial, the difference is only 100. So postprandial is not a much issue. We only need to tackle fasting sugar. But why this postprandial is not an issue? Maybe because the glimepiride is acting. So since glimepiride is already on a reasonably high dose, there is no much point in hiking it further. But you can try to maximum dose 6 to 8 milligram, but it is not commonly practiced. Or you can add another OHA like DPP4 inhibitor or SGLT2. But the best way is to add a basal insulin on top of these two OHA. We retain metformin, we retain glimepiride, but we are going to add a glargine at night. This glargine can control the fasting blood sugar. When the fasting blood sugar is controlled, PPBS will automatically become normal. You can ask me why I am adding glargine on top of glimepiride in this case. Here, diabetes only 5 years, beta cells are not fully exhausted. The glimepiride is the glimepiride which the patient is already on is acting. This PPBS is under control. There's no much difference. The difference between PPBS and FBS is only 100. This may be because of the glimepiride which we are giving. If you take away the glimepiride, then post-meal surge will become more. So that is the reason which I do not want to take away the glimepiride. I just add a glargine on top of it to control the fasting sugar alone. And with only one prick insulin, we can control his sugar. It is possible to take away the glimepiride, but in that case, postprandial sugar need also be targeted with insulin. So glargine alone may not be enough. For that, you need to give premixed insulin morning and night or a basal bolus. So it will increase the number of pricks. But if you retain these two medicines, you can manage with only one prick. There is no harm in adding premixed insulin morning and night along with metformin, taking away glimepiride. It is very ideal. But adding a glargine on top of this is also an option because it can decrease the number of pricks. We should always consider the number of pricks when we are prescribing insulin because pricks are not comfortable. For us also, it's not comfortable. You try getting insulin pricks, it's not comfortable. So we have to acknowledge that also. Now we go on to case number 7. Here we have a 55-year-old female, diabetic for 15 years. She is obese. Patient is on metformin 1 gram 2 times. Premixed insulin 40/030. Fasting blood sugar is 250. Postprandial blood sugar is 400. HbA1c is 10.8. How are you going to manage? Here fasting sugar is high, postprandial blood sugar is high, average blood sugar of the past 3 months is also high, HbA1c is 10.8. So patient is already on optimal dose of insulin, a very high dose of insulin. So are you going to hike the insulin dose further? That is an option, but before that you need to check a list of things which I am going to detail now. Please check whether the patient is on any concurrent diabetogenic drugs like steroids. Motivate the patient for weight reduction. This patient is having type 2 diabetes mellitus, and even with this very high dose of insulin, sugars are high. It may be because of the insulin resistance. Bringing down the weight will reduce the insulin resistance, and with the same dose of insulin, maybe patient can get a good glycemic control. Diet modification, maybe patient is overeating, that should be also addressed. So that's are the basic things. In addition to this, there are certain specific things you need to ask. How frequent do you change the insulin vial or cartridge? Here the patient is on 40-0-30, that means the daily requirement is 70 units. One insulin vial has 400 insulin units. One insulin cartridge for pen has got 300 units. So if the daily requirement is 70, if a patient is using insulin vial, then that means the patient has to change the insulin vial every 5 to 6 days. If the patient is using cartridge and insulin is delivered using a pen which has only 300 units, then a patient needs to buy new cartridge every 4 days. Suppose the patient is telling that he or she is changing the vial only after 10 days or 15 days, or changing the cartridge after 10 days or 15 days, that definitely means that patient is not taking the prescribed dose of insulin. Either patient is skipping insulins or taking lesser dose of insulin, knowingly or unknowingly. So the frequency of changing the insulin vial or cartridge is the best way by which you can know whether patient is receiving the prescribed dose. If you ask the patient whether you are taking the prescribed dose, most of the patient will tell yes. They may be purposefully telling yes, though patient is purposefully lowering the dose or skipping the dose, or there may be patients who unknowingly take lower dose of insulin because they do not know to take the correct units in the insulin pen or syringe, or they use another different insulin syringe which it is not concurrent with the unit concentration of the insulin in the insulin preparation which we prescribe. So the best way is to ask the patient, how frequent do you change the vial or cartridge? If you find a fault in that, then correct it. You do not need to hike the insulin dose. But if the patient passes this question, then ask the next question. Is there any nocturnal or early morning hypoglycemic episode? Or is there any more frequent hypoglycemic episode? If there is a hypoglycemic episode, if it is nocturnal, due to the Somogy phenomenon, fasting blood sugar will be high and PPBS will be automatically high. If it is a Somogy, you are not supposed to increase the insulin dose. You are supposed to reduce the night dose of insulin. To pick up the Somogy, sometimes patient may not report the hypoglycemic episode. You have to ask the patient to wake up early morning at this time and check his blood sugar using a glucometer. And if a patient is having a recurrent hypoglycemic episode, patient will skip the insulins, will take sugar, glucose, additional food at that time. So frequent hypoglycemia can also result in higher blood sugar. If the patient passes that question also, that means there is no early morning hypoglycemia and there is no frequent hypoglycemia, then you go to the next question. Show me the site where you are injecting the insulin. If the patient takes the insulin repeatedly in the same site, what will happen? The fat in that area get damaged, and it is called lipohypertrophy. If there is a lipohypertrophy, if you're taking insulin again to that area, patient will not get the pain of the prick. Patient will have painless pricks. So patient tends to take insulin in the same area. But here, the injected insulin is not absorbed into the circulation. So insulin cannot act. Even if the patient is injecting the prescribed dose in the area where there is lipohypertrophy, insulin is not going to act properly. So that can also result in higher blood sugar values. So you need not have to change or hike the insulin dose. You just need to change the area and teach the patient the correct insulin injection technique. So where should the patient inject the insulin? The injection should not be happening in the same site. If it is happening in the same site, lipohypertrophy will occur. You need site rotation. One option is divide the abdomen into 4 quadrants and each quadrant rotate the site. And after one quadrant is finished, then go to the next quadrant, next quadrant, next quadrant. Similarly, wherever the patient is taking insulin, the sites need to be rotated. Next question is, you should ask the patient to show the insulin syringe if the patient is taking insulin using a syringe from a vial, or ask the color of the insulin syringe. There are 2 insulin syringe available here. One is 100 unit insulin syringe, second is 40 unit insulin syringe. There are also 2 insulin preparations available as well, 100 IU per ml preparation and 40 IU per ml preparation. Always keep in mind that 40 IU per insulin preparation should be taken only with 40 unit insulin syringe, and 100 IU per ml insulin preparation should be used with only 100 unit insulin syringe. Both insulin syringe is only 1 ml syringe. 1 ml is divided into 40 equal units for 40 unit insulin syringe and 100 equal units for 100 unit insulin syringe. 40 IU per ml preparation means 1 ml of insulin contains 40 unit insulin. 100 IU per ml preparation means 1 ml of insulin contains 100 units of insulin. That is a concentrated insulin. So 100 IU per ml insulin with 100 IU insulin syringe, 40 IU per ml insulin with 40 IU insulin syringe. Suppose the patient is taking 40 units of 40 IU per ml syringe in a insulin, 40 units of 40 IU per ml insulin in a 100 IU insulin syringe. That means knowingly or unknowingly patient uses 100 IU syringe. Patient is only actually getting 16 units of insulin. We think that patient is getting 40 units. Patient thinks that patient is getting 40 units, but in reality patient is getting only 16 units because patient is only getting 0.4 ml. The insulin syringe has 1 ml. Patient is only 1 ml is divided into 100 units. Patient takes insulin up to only 40 units. 40 means 0.4 ml. So patient is taking 40 IU per ml insulin, only 0.4 ml. So that means patient is only getting 16 units insulin. So you have to ask the patient which insulin syringe you are using. In Western countries and outside countries, the common preparation available there is 100 IU per ml, and definitely syringe will be also 100 units insulin syringe. The relatives of the patient will bring bulk number of syringes from foreign countries to here and give it to the patient. But our patient buys 40 IU per ml insulin from here because 40 IU per ml preparation is a commonly available preparation here. So that is a common way by which mistakes do happen here. Then you have to probe into the insulin injection technique. Already I discussed about the site rotation. The insulin should not be is constantly injected into the same area, you have to rotate the site. In the same area, you have to divide the area, and in the same one area, you have to again rotate. Then how you are injecting? You have to lift the subcutaneous layer with the skin and inject perpendicularly. If you are injecting without lifting the skin, if the patient is very thin build, that means the patient is having very less subcutaneous fat, the needle may go up to the muscle. If the insulin is injected into the muscle, all the insulin will be absorbed fast and all the insulin will act in 1 to 2 hours time, and it can result in hypoglycemia in the initial few hours, and later there is no insulin available to act, so patient will develop hyperglycemia. So if the patient is injecting insulin and if the patient is having thin subcutaneous fat, you have to ask the patient to lift the skin fold, and the injection should be perpendicularly. If the patient injects tangentially, the insulin is not going to go into subcutaneous tissue, it may go intradermal. So intradermal insulin cannot be absorbed properly, and patient will not get a good sugar control. And site is also important. 3 common sites are upper arm, abdomen and thigh. So which area should be preferred? I advise everyone to use abdomen, because abdomen, the area is very large, so patient has enough space to do the site rotation. In the abdomen, don't go near the umbilicus, because near the umbilicus the vascularity is more and pain will be also more. So 3 fingers away from the umbilicus, you have got a large area where you can rotate easily. So same site will get the next prick only after so many days. The problem with arm and thigh is the area is less, and also these are limbs are constantly moving. If the limbs are moving, the insulin injected into the subcutaneous area get absorbed fast, so it can result in hypoglycemic episodes in the initial hours and hyperglycemia later on, because all the insulin injected will get absorbed in the initial hours. But the abdomen is an area which is not that mobile as arm and thigh. Also, if the patient is injecting by himself or herself, it is very difficult to inject to the arm. So it is always better to ask the patient to use abdomen as the preferred site. So I have asked this patient a lot of questions, and if everything is okay, that means then only you are supposed to hike the insulin dose. And also that means the patient is having severe insulin resistance, because patient is already on 70 units insulin but sugars are not getting controlled. So either you can add a pioglitazone. Pioglitazone is a medicine that can lower the insulin resistance just like metformin, but it is not very preferred because of 2 reasons. One is salt and water retention resulting in edema, and second is risk of bladder cancer. It is not proved, but there are some concerns. So we are left with only one option. We have to hike the insulin dose. So I hiked the insulin dose 50-0-40. You will ask me why I hiked this much. From the 40, I hiked to 50. From 30 to 40. In the previous session, I told that hiking the insulin is by only 2 to 4 units. But why I hiked to this large extent? This is because I know that this patient is having severe insulin resistance. Sugars are very high. For a 2 units of this 10 units hike is as good as 2 units hike for a patient with less insulin resistance. Because the insulin resistance is more, a 2 to 4 units hike is not going to make much difference. So that is the reason why I, with confidence, hiked to this heavy dose. So my new prescription is injection premixed insulin 30/70 50/0/40. Is this prescription correct? I have told I have hiked 10 units morning and night. So now it's become 50/0/40. Is this prescription correct? It is not correct. If the patient is using an insulin vial and syringe, the common preparation is 40 IU per ml. And they are taking with a 40 units insulin syringe. How can they take a 50 units? The marking is only up to 40 units. In a 40 unit syringe, patient cannot take 50 units. It's a common sense. So if the patient is using vial and syringe, then we have to ask the patient to discard the previous 40 IU per ml vial and 40 IU insulin syringe and buy 100 IU per ml insulin, which is a concentrated insulin. 1 unit has 100 units insulin, and buy 100 IU insulin syringe and ask the patient to take this prescribed unit with this new insulin and new syringe. So the prescription should be insulin premixed insulin 30/70 100 IU per ml 50/0/40 sub-Q 30 minutes before food. 30 minutes before means regular insulin will take 30 minutes to act. So it should be 30 minutes before food using 100 IU insulin syringe. Or patient can take the insulin in a pen. Pen is 100 IU per ml and you can use up to 100 units insulin in the pen per day, per shot. Thank you. In the next, we will proceed to session 3.